Why don't you tell us just a little bit about yourself? I just want to preface this by I've sort of stalked you a bit on Threads and Instagram, and it's super nice to always see people putting good evidence-based content out there. And I've certainly seen a lot of great evidence-based content. And just again, to remind people who are just coming on, I'm doing a Substack Live with Dr. Hollie Wakelyn. So why don't you tell us a little bit about yourself?
Sure, sure. Thank you. It's an honor to be stalked by Dr. Jen Gunter. I'm new at it, so it's nice that the content is making it out there. So I am a pharmacist. I am board certified in ambulatory care, and I'm a Menopause Society certified practitioner. And I'm also a practicing pharmacist per diem at a large pharmacy, and I've done many decades of various types of pharmacy. And I'm just really happy to be able to be discussing evidence-based medicine. I think that the pharmacy world kind of isn't heard from a lot unless you're a compounding pharmacist or if you're somebody selling something. And I'm not. I'm an educator, so I'm happy to be here.
One model that I think, as we have made medicine cheaper, for lack of a better word, I mean, the people at the top are still making the money, but where we've like cut corners is, when I was a resident, we had a pharmacist on every inpatient team, and we rounded every day with the pharmacists. And it was so valuable because of all the drug interactions. And this was in Canada. And in fact, drug companies couldn't come in and give us a talk unless there was a pharmacist at the talk.
Oh,
Oh, yeah.
that's a great idea.
Yeah, it was very, very regulated. And I think about now even, like, for example, I prescribe a lot of high dose fluconazole because I see a lot of people with resistant yeast. And I've also got people on, SSRIs and other drugs that, can affect the heart. And I'm always like calling my pharmacist, like, hey, can you help me out? What do I need to do with this patient? So I think it's really important for people to know that pharmacists play an incredibly valuable role in helping us, especially with very complex patients. And because of all the cost cutting, like, we just don't have the same access. And so that's just a big issue. So I'm very grateful to have experts like
I think that's a great point, and I think probably a lot of folks who go into their regular ambulatory care or retail pharmacy don't understand the years of education that we have and experience. So we have doctorates, and that last year and a half, typically of school, is spent rounding with physicians like yourself, with nurse practitioners and PAs, and it's an interdisciplinary model. And we bring medication expertise to help complement the diagnostics and be able to treat in a interdisciplinary world, and procurement, right? So we know clinical evidence, but also we have to obtain it, and we have to prepare it. Sometimes we have to distribute it. We have to own that product. So you can recommend a treatment. Dr. Gunter can just prescribe whatever, fluconazole, 200 milligrams, and that patient needs to get that fluconazole somehow. So we're involved in almost every aspect of medicine.
So, and I also think it's really important that don't get mad at your pharmacist
Yes.
when a drug is not available or when there's an issue with your doctor's prescription. I know it's so easy in this, it's the same way, like, don't get mad at the person checking your flight in. Like, they didn't do any of this stuff. And so it's just kind of a plea that, they are, if you are exasperated, I bet your pharmacist is just as
Oh
exasperated.
yeah. Thank you for saying that. I can hear the cheers of pharmacists all around the world right now, because our goal is to provide care, and we don't want to hold medications hostage. Of course not. And it takes a lot more time to have to, kind of calm people down rather than just give you your medication. And so thank you for saying that. That's so important. We're bullied all the time. It's a difficult profession right now.
Yeah, I can imagine. And certainly I know that when I walk past our pharmacies and they're just like swamped with people, and I know there's a big push to push everybody online to get medications. And I actually, before we dive into talking about, the medication shortages, I'm just curious in your take with that. I mean, and I'm not talking about the person who's been stable on a medication for a long time, but although I just wonder, like, if you've been on a medication even for years and maybe you're having a problem, if everything's getting filled online, you are kind of missing that interaction where the
Oh,
pharmacist might say, "Hey, how's everything going, Ms. Smith?"
yeah, yeah, it's kinda like a primary care model that is fading into the background too, is like creating that relationship with patients. And even if you have been on medication for years and years, you might be started on a new medication, right? So you might have been on your levothyroxine for 20 years, but then you were started on a new medication, and there's an interaction there. And you're not it's very difficult to get a hold of some of these mail order pharmacists if you do have a question, to get through all the phone trees and to press number 1, press 0, and whoever you speak with. So creating that relationship with your neighborhood pharmacist, I think it's highly valuable, because then we can talk about things like, how's your family? How do you need a vaccine? When was the last time? What did you hear in the news, right? Or did you see that social media post, and help try to provide some real expert information?
Yeah, I mean, back in the day, we used to have Dixon's Pharmacy at the end of our street,
Oh,
run by Mr. Dixon, which was a block and a half away, and we got all our prescriptions there. We also, went to buy our newspapers, and I bought candy there, and, menstrual pad, like, it was, what a 7-Eleven sort of is now, in some ways, but there was a pharmacist, and you knew Mr. Dixon, and
mm.
Mr. Dixon knew your mom, and, if there was an issue, Mr. Dixon or his lovely, pharmacist would, chat with you, and they knew what was going on with your family, and I just do feel that we have so much convenience in medicine now, and I think that's wonderful, but the human touch also, I think, is super important, and I'm lamenting the loss of Mr. Dixon's
Oh,
pharmacy.
I totally understand. It's that plays into the art of medicine rather than just the data driven stuff, which is very important. But that relationship building is key, and we can help you with over the counter medications. We can help you. Your baby's constipated, or your dad started a new Alzheimer's medication, or maybe you need a resource for a mental health person in your community, or there's so many connections that we can make rather than levothyroxine number 30, take one by mouth a day on an empty stomach, right? Like there's so many other things that we could do if we were given a little bit more latitude in the corporate world.
Right. Yeah. Everything's the fault of billionaires. That's my new thing, right? If people only become billionaires by exploiting people who need the services, that's the company. So,
Oh yeah. Oh yeah.
um, so with that, I want to segue and start talking a little bit about menopause hormone therapy shortage, which I've seen circulate again. And I wrote a post about it, I guess, almost 2 years ago, a little bit over 2 years ago, because this has been a long-standing issue. And there's very complex supply chains. And you had graciously commented and said that you thought that the piece that I wrote was kind of spot on. And I'd love to hear your take on the medication shortages.
Oh, sure, sure. I think you make a really good point about all types of medication shortages, that this is something that we would deal with very commonly in the pharmacy world. And it's a struggle for especially type oncology type medications and truly life-saving medications. And MHT is really one of them. And I felt like your post gave such a great background into how complex it really is. And none of us know the full story, the opacity, I love that word that you used. It's we don't know the full story, but there is so much behind the scenes with the active pharmaceutical ingredients and those contracts that are created, and there's so many contracts between manufacturers, so the API producers, the manufacturers, the PBMs, the pharmacies, the insurance companies in the US, and then the global market, which is affected by taxes and tariffs and political environments and climate change. And it's very complex.
Yeah, and so many people are taking a cut at different levels, and and I think one of the issues with that's fairly unique. I mean, many medications are actually made semi-synthetically, meaning that they come from a plant originally, but it's not grinding it with a mortar and a pestle. Like, let's be honest about it. But it,
Can you imagine if we were still doing? I kind of miss those days of just putting stuff into a mortar and pestle, and that's the neighborhood farm. Maybe Mr. Dixon did that for you.
yeah, Mr. Dixon might have done that. But yeah, so when you have, you're basically dependent on crops in a couple of countries, and so if there's a hurricane or drought or whatever to affect that area, you can wipe out masses of, the raw material that you need to start with, which is
Yeah.
kind of interesting because you're hearing all the soybean farmers here talk about how Trump's tariffs have screwed them over and they can't like sell their soybeans. And I'm like, well, it's kind of ironic that we have shortages and then here we have soybeans that aren't quite used.
Yeah.
Um, but I think it's just also important for people to understand that, this is like nobody can pivot on a dime. This is highly complex, like taking stigmasterol from a soybean and breaking the bonds and making it into another chemical
Yeah.
is,
Multiple other chemicals in that
yeah.
case, right? We have to create multiple hormones from that. And I think your point about natural disasters is really important too. Climate change being one of them that's affecting, in this case, we're talking about the soybean production. But, you even mentioned in your post about Puerto Rico and Hurricane Maria. And I was actually deployed to Hurricane Maria back in 2017. I'm a former U.S. Public Health Service officer, and one of my big jobs was to build field hospitals in places of crisis. And I was there to build a field hospital, but you can see the infrastructure in Puerto Rico during that hurricane season created, massive power outages, and people were just trying to find their families and trying to survive, find shelter. And so a lot of drugs are produced in Puerto Rico. So what happens when something like that, a natural disaster hits a one location, then the whole supply chain starts to break down.
Yeah, and I think this is a real big problem with capitalism, right? Because, capitalism and healthcare really don't mix because capitalism wants the leanest, meanest, supply chain. One supply chain, boom, make it easier. But one factory goes down and you're done. I
Yeah.
mean, during Hurricane Maria, we were rationing lidocaine. Yeah, injections for lidocaine because we had very few sources. And you're like, well, they need it in surgery. And it's not that, anybody I think suffered, but it was like we had to be incredibly thoughtful about the medications that we use. And I think it's a good reminder that in many countries, people have to be very thoughtful about the medications they use. And sometimes we're sort of used to everything being available here. So I think that's why when people are having trouble getting their menopause hormone therapy, it's such a new thing to them.
Yes, yes. You mentioned lidocaine and needing it in surgery, and these are things that you and I have dealt with for years. Is you won't have a product that's available. What can we use? What can we substitute it with? And then that product gets depleted, and
Right.
so during like COVID when I was building field hospitals in COVID, and we had a massive need for ventilating drugs, right? So you need narcotics, you need the paralyzing drugs for when you're being ventilated, and the supply was not readily available. And these are people who are life threatening situations. Gone are the days of the huge warehouses of drugs. We have just in time deliveries. Even when I was in Africa, we had to have systems where we were able to get drugs more rapidly. And then we don't really carry a lot of inventory in regular pharmacies because that's a lot of money. You have a couple $1 million of inventory sitting on your shelves waiting to be used. And maybe they expire, maybe they don't get used, maybe there is some sort of thing that happens to them. It's so tenuous. You break one part of that cog, then the whole thing kind of shifts.
Yeah, I mean, think about a pharmacy and say there's a flood and you've got, a couple $1 million worth of drugs on your shelves. Then,
Yes, that happens
yeah.
a lot.
So, or things in the freezer, power goes out. I know a lot of doctors, have had their whole, like, who give vaccines in their clinic have like lost, hundreds of thousands of dollars worth of vaccines. And that's not something that most doctors carry insurance for.
Yes, yes. And then there's things that have to be frozen, and there's things that have very sensitive temperature ranges. Some products can be left out for a period of time out of the refrigerator, but it takes a lot to research that. Even in the DoD, we had. I used to be in the United States Navy. We had a program called the Shelf Life Extension Program.
Mhm.
So there would be reviews of products that we had for for kind of a disaster response situation. And so you would extend the beyond use states of some of those products. But you have to, that takes so much time and testing and energy. And I know we're kind of being doom and gloom about it, but this is a good thing. Like, we want to have reliable medications that are safe, that are going to help people, that wasn't kept in somebody's glove box during a flood. You want to ensure that what you're taking is safe. And that's kind of part of my platform here is I want to, especially in the menopause hormone therapy world, when there's a shortage, some other people can enter the field, and there's a gray market, and I've even seen advertisements on my social algorithms for BHRT providers. Are you ready for the shortage? Are you ready for the onslaught? And these products are mostly compounded that have less than scrupulous regulatory authority sometimes. Sometimes, they're reliable, but we don't know, and we don't have data to know that. So the gray market here, potential during shortages, fires up.
Yeah, I think that's a really important point. So, people don't understand. I think a lot of people don't understand that compounded hormones are not something that any valid expert recommends unless
Correct.
you have a true allergy and there isn't, a standard pharmaceutical equivalent. That would really be like the explanation because we're not dealing with pediatrics and the kind of doses that tiny children might need. So,
Yeah.
and the
There's
importance,
times you'll need to compound into a J tube. Someone can't take things
right?
by mouth, or like you mentioned, allergies, or there's definitely a role for compounding, but there's a lot of money in it for people who are wanting to market it. The bioidentical craze. I know you've talked about a lot. I do as well. This like bioidentical is such a marketing term. You can get them from me in a regular pharmacy from your health insurance. Nobody's, how I know it's marketing is because no one is coming up to me and asking me for bioidentical Xanax. Do you have any bioidentical Vicodin in your pharmacy? The only bioidentical question is hormones.
Yeah, and I think if the one take-home message people could have, and I posted about this before, is bioidentical estradiol is the same as
It's the
estradiol.
same. You had a funny meme. I want to look that up again. But the funny
Yes,
meme of the estradiol, structure, molecule structure, and it was the same as the
yes,
bioidentical, and I love
yeah.
that.
It was the Office meme where he's pointing.
Yes, it was
Yeah,
Jim from The Office.
yes,
So good.
it, exactly. It's on my site. I always tell people bioidentical estradiol is like saying a two-wheeled bicycle. The name is in the name.
It's a
So
bicycle.
yeah, right? Like estradiol is estradiol. It has to be like it's a made up word anyway, but it has to be bioidentical. Progesterone has to be bioidentical. And if you know that those are the two hormones made by the body that we would also prescribe, they have to be bioidentical or they would have a different name. And I think that it's important for people to know that.
And we want access to everybody because people hear something like bioidentical hormones and they think they can't afford it, or they can't go to the clinics, or they don't have access to it. It's a certain demographic that does, and it's just not true. If your provider and your clinician decide with you that that is the therapy of choice, then everyone should have access to it.
And I think it's also important to point out there are times when non bioidentical hormones might be preferred. And, one good example is the progestogen that you might use. Many people have bleeding problems with progesterone. It's not as strong for counteracting the effect of estrogen on the uterus. Some people do better with a progestin. People at higher risk of endometrial cancer, we might prefer to have you on a progestin because you're going to get better protection. So it's really important that we not demonize whole classes of hormones in the same way that, Premarin has been demonized by a lot of people. It is the only estrogen that's been shown to be associated with a reduced rate of breast cancer, right? So that might be important for some people. So I just think it's very important. And I know that we're on the same page here that we say, look, the more choices you have, the better.
Yeah, and if you are if hormone therapy isn't right for you, that's okay too, right? There's a lot of nuance, and we have a lot of other non-hormonal medications that we can provide you with, and so it's very nuanced. You know, you have to talk to you can't get it from 30-second Instagram videos. And if they're trying
Right.
to sell you something, maybe consider that when you're taking medical advice.
Yeah, I mean, if somebody is selling you a supplement or somebody is selling you the hormones that they're going to insert, or selling you the hormones that are going to come from their compounded pharmacy, then they have a bias. And I always tell people, would you, get your health information from Merck if you were using one of Merck's products? No, you wouldn't. You'd say I should probably go to somewhere else. So I think that's a good point. So I want to get to a question that came up. I had emailed out to let people know that we were chatting, and somebody said that they were switched to generics from with their estradiol patch, from Sandoz to Mylan. I think it's Mylan. And I know that we have any data to say that people would notice a difference, that these products should really be equivalent. What are your thoughts on that?
You know, there are women who are sensitive to certain products versus the other, especially with patches, because of the type of adhesive that is used. And in the twice weekly patches, it is a matrix style where the estradiol um, is kind of complexed into the matrix there, and it releases over a period of time, 3.5 days ish, and that matrix is different for different patches, even though they're estradiol, whatever, 0.05 milligram. The types of adhesive can be irritating for some people and can release maybe a little differently on your skin. There is a range that's allowed for generic products when the FDA approves them. There's a range, and something like sensitive, even though they are the same, there are some drugs that you're very sensitive to, hormones being one of them for some people. There's not there, you're looking at an aspirin that's aspirin products. Aspirin, you'll have multiple generics, and there is a range again for that. But are you going to notice the aspirin, that tiny little range? Less likely. Hormones definitely. Some people feel more sensitive to, but separating that drug that's in that patch versus the delivery system, it can be complicated.
Yeah, I would say definitely that the patches and probably the gels as well, because and the lotions and all of that, that some people just have a different response to different products. I mean, there's some people that whatever, use Aquaphor and love it, and use something else and that's got similar ingredients but maybe not quite the same, and they hate how it feels on their skin or makes their skin feel dry, and all of these things can affect absorption. And so I think that I usually tell people, give yourself a couple weeks if you can, to see if you kind of get, to sort of your steady state. And if it's problematic, then you may have to switch back or consider a dose adjustment depending on what your symptoms are. Because you could also be absorbing, like people often don't think this, you could also be absorbing more. It's not necessarily you're absorbing
Yes,
less.
the range is, you have the middle, you have plus and minus, and you could have that range there for approvals for generics. So you
Yeah.
might be on this side, or you might be on this side.
And I always tell people that if you've made a switch and now you're getting breast symptoms or you're getting headaches or you're more mood symptoms, those are typically more aligned with high estrogen symptoms. Those are symptoms people tend to get in perimenopause with loop ovulation. And so just to keep that in mind, the answer may not be to increase the dose. The answer might be to decrease it. And that's why it's important to talk with someone, who has an understanding, like a pharmacist who's got experience or a physician who has experience in the area.
And if you find one that does work for you, shortage aside, you can request to a particular manufacturer. So you can ask your pharmacy. This is another example of our neighborhood pharmacy. It'd be very hard to ask the mail order people to give you a particular manufacturer, but you can typically at your regular pharmacy say, I do better on Sandoz, and we can try to order the Sandoz for you.
Yeah, I mean, where it gets complex, as you know, with like big systems, is that they strike deals with, this year we're getting it from Mylan, and this year we're getting
Mhm.
it from Sandoz, or maybe Mylan's got a shortage, so we have to get it from Sandoz. Like there isn't an option because
Or there's a higher rebate for one of them versus the other,
exactly.
or it's a vertical integration system that we have where a particular pharmacy has a particular doctor who has a particular health insurance and who has there's so that vertical integration sometimes gets to us as well.
Yeah, but people definitely ask, and so for me, because I order 'em obviously my prescriptions all electronically, there's a place where I can add extra information, and I say, patient specifically requests this, and then, hopefully that gets taken care of, and of course, some of it's gonna depend on even the specific plan that you've purchased. So, some plans might allow it, some might not, but I think if you're going to something like, cost plus drugs, like Mark Cuban's site, you're not going to have that kind of control. I don't. You might be able to. I think it usually says what it is, but what you order might not be what shows up because stocks could change in that 24 hours.
Yes, yes. And regular pharmacies, we have to pay attention to how much we're getting reimbursed too. So if the pharmacy is going to make $3 more on the Mylan, they're gonna dispense the Mylan. So it's good that you put your notes in there for us that that the patient does better on that particular generic, and then we'll do what we can to
Right.
make it happen. We can do that with brand names too. You do your dispenses written DAW1. There are some medications, seizure medications is one I can think of where sometimes people just need to stay on that particular type of product. And so there's designations for that. And we do our best. The pharmacies are not trying to make it
Yeah.
difficult for anybody. We want people to get their medications. But it's such a complicated system of being in the middle of your health insurance company, the corporate structure, and your providers.
Yeah, and I think a lot of people don't understand the role of pharmacy benefit managers and how. Do you feel comfortable talking a bit about that?
Sure, we can talk about that.
Yeah.
Yeah, so pharmacy benefit managers, for people who haven't seen this, you might have seen the acronym PBM out there a lot. And PBMs are, we're going to call them middlemen, even though they're huge entities. And there's a lot of discussion about translucent. We can't figure out what is happening internally with some of these PBMs because of proprietary reasons and some regulatory protections. So you might see PBMs being discussed in the news a lot, but they're the ones that help to facilitate transactions at pharmacies and also doing contracting for pharmacies and health insurance companies, amongst others. But where sometimes there's trouble is within that vertical integration system where the PBM is also part of the overall structure. They own a health insurance company, they own a pharmacy, they own a clinic, and so there's been a lot of, I would say, grassroots movements from especially independent pharmacies and folks that want to know what's happening with the money. What is when we get paid this money or we make this contract? What happens in that middle ground with the PBMs?
Yeah, I think, somebody asked, why is it so difficult in the United States? And I would say that, we're suffering from the late stages of extreme capitalism. In the 1950s, they didn't have billionaires like this. People don't have, it's the end result of allowing people to profit off of the American public. And I would say the government here doesn't really exist to serve the population. People exist to get reelected. There's a few that do. There's a few good politicians, but when you look at how easy it is to just give things over to the corporate structure, to for the government to abrogate responsibility, that's what happens. Versus in countries with entrenched, universal health care, even ones that have a two-tier model, their second tier is not the expense that it is here in the United States. People are like, oh, I spent €100 to go see a specialist as opposed to $3,500 here, right? So it's a whole different access, and there's no incentive. For example, in Canada, brand name drugs have a much lower price because the government negotiates with, with the companies. And I think this we're seeing with, Moderna, like, I don't know if people have heard, but, Moderna submitted their mRNA flu vaccine. The FDA wouldn't even look at it. And now they're saying, well, maybe we're just not going to do any more mRNA vaccines because, the US is one of the biggest markets. And so that's what happens when, it's capitalism over caring. So it's really sad. I mean, so we just do the best that we can. We're saying, well, okay, you're struggling to get this medication. We can't fix the corporate system. Although educating you about what's going on, super important. Talk to your elected official, talk to your the people who represent you. I think that these kinds of things, because they're specialized, I bet you your politicians don't even know about what's going on, most of them.
I think that's sometimes by design too, especially in the healthcare arena. Is it's hard to know how much things cost. When people ask me why does a drug cost a certain amount of money, there's really no easy answer. So even going to a provider in a different country, usually those are pretty transparent, the prices and how much you're going to pay. But in the U.S., it is difficult to find out what you're paying and why. And I think advocating for that transparency with your lawmakers is key. It does matter. I think sometimes people think that, oh, their voice doesn't matter, or I can't understand it, or it's not that big of a deal, or it'll all work out. I think we're kind of past that now. I think we need to learn, like everyone is doing, watching this, which is great, and then advocate and talk to your lawmakers and let them know what it is that you want.
Yeah, I think that it's really important to realize that you can't have a voice. And I think it can get very overwhelming with everything that's going on. And I always tell people, just pick one passion project. Pick one thing that really motivates you. There's going to be somebody else who's interested in a different thing to advocate about. And if you think about all the things in healthcare that need to be fixed, you'll never get started.
Oh my goodness, where do you even begin, right?
Yeah.
But it is overwhelming, and that's a great point because being overwhelmed sometimes causes inactivity, and you need to one step at a time find something that you are passionate about.
Yeah.
And likely somebody else is as well. We have 330 million people in this country. I'm sure somebody else
Yeah. And it's
thinks
great
the
to
same
have.
way you do.
Yeah, and it's great to have the community. I mean, just doing this, there's 330 like-minded people probably, who are like, why is the supply chain so bad? And maybe somebody knows somebody who's in politics. That's how it sort of gets started. Or maybe someone's going to say, well, shit, I'm going to run for office then. Um,
Great. That'd be awesome. Do it.
yeah. So, anyway, yes, and obviously we're not going to solve the political issues. So I have, made some suggestions for people. I've got a post that I'm going to put up tomorrow just about different options for estrogen choices to kind of switch in between. And there's a couple of things, people, I just thought it'd be nice to kind of review them as well. So, one option is to ask, is there a brand name available? Your insurance is going to default to generic, but brand names tend to be more protected because they've protected their supply chain. So do you think that's a fair strategy?
I do. I think you can ask the pharmacy what do they actually have because there's multiple manufacturers of generic patches. So maybe they have another one that you haven't even heard of. And the ASHP website, I think you put a link in there in the agenda. It lists the manufacturers that are available and that's something called an NDC, which is a national drug code. That is what we use to process all our prescriptions. So ask the pharmacy what they have and they will hopefully give it to you. There's once weekly patches too that sometimes there's some of them are a little bit on shortage. You'll see that on the list, but once weekly isn't can be an option. The daily gels, of course, we have the sprays, the estradiol sprays. I think the Femring is not talked about a lot. It
Yeah.
is a brand name product, but it's a ring that you insert for 3 months and it gives you systemic levels of estradiol. And it is expensive. And, I'm sure there's people who are like, oh, well, my insurance won't cover any of the other things. And that is true for a lot of people. And that's that's also what makes it hard, right? Your clinician can recommend using the Femring, for example, but your insurance won't cover it, but you can't get the patch. So it can be a complex process.
Yeah, I think people sleep on the Femring a lot. And also if you're using the Femring, then you don't need to use a vaginal estrogen if you're having, kind of those issues too. So it kind of, because you're getting absorption through there. And so I prescribe it a fair bit. People love the every 3 months, and that's a good option. Yeah, so Femring is what it's called. And if you see my post coming up tomorrow, you'll see where it falls in the dose equivalencies. Another transdermal that I think people sleep on is the Comba patch, uh,
Mm.
which is an estradiol patch with, I think it's got norethindrone in it, or yeah, no, anyway, one of the progestins, I can never remember.
There's Climera Pro as well.
Yeah,
So you have Climera Pro and Combat Patch,
yeah,
and they have different progestogens, and one's a once weekly and one's a twice weekly. But those are options. There are no generics for those that are available yet. But that is option. And, oral estradiol is an option too. I think there's a lot of kind of, again, misinformation out there about oral estradiol versus transdermal estradiol, and that is something you can bring up with your clinician and find out what your risks are and what's available for you, because that can be quite cheap.
Yeah, absolutely. And I tell people that, if you're, under the age of 60 and don't have any risk factors, then that might be the easiest switch for you. Any risk factors for clotting, switching to an oral, because it's also can be very inexpensive. And also depending on the dose too, I would be less comfortable with a 75-year-old wanting to switch, to an oral versus, a 55-year-old, just because your risk of clotting increases with age, right? And from that standpoint. But, also if it was a super load, if they were just taking a whiff, then, you have to kind of all put it on.
A whiff of, I look forward to filling your prescription for a whiff of oral estradiol once a day.
That's what we used to call it, when you've got somebody like on a point taking point 0.3 Premarin and they're cutting it in half and they're like, no, that's perfect for me. I'm like, okay, that's a whiff. If you like it.
Okay, we did talk about people being sensitive to hormones, and so that is a possibility.
I think
One whiff of
one,
Premarin, point 0.3.
I'm always like, if it's not broken and it's not going to harm you, then I don't need to fix it.
I totally agree. And if you do get changed to a different formulation of estradiol, it doesn't have to be forever, right? Like, we are working through these challenges with the shortages. We are working to bring awareness as you do so well, and you don't have to be on the once weekly patch forever, right? There will be changes that occur, and especially during perimenopause anyway. There is likely going to be changes anyway of dosing, and just try to be a little flexible, and understand that the pharmacist is doing the best they can, as is your clinician, because now they have to answer all of these different phone calls, and they have to figure out what dose to change you and what is the equivalence of a Femring 0.05 with a once weekly patch. Or, it can be very time consuming, and then processing it through the insurance company. Can't
Right.
even get started there.
And, another option for perimenopause are the ultra low dose birth control pills. And
Yes.
that those are, first of all, they're often a better choice. And I've done videos explaining loop ovulation, and I would really encourage people to go look at that. But we don't tend to have pill short. It's uncommon. I think maybe because they have such long shelf lives. I don't really know, but there's low dose pills. There's also Nextstellis, which people do very well on as well if they don't like ethinyl estradiol. So I just put a shout out for people in perimenopause who are having issues. And I'm actually our birth control pill is synthetic. So every single medication that you take is made in a lab, with the exception of Premarin, which is just extracted from horse urine. Synthetic, semi-synthetic are the two different ways that we make hormones, and those do not imply safety. So I think it's super important. And if somebody's telling you should be scared of a medication because it's synthetic, then you should not follow that person because they're ignorant in biochemistry. It
Yeah.
is what is studied and what we know. And some people do great with ethinyl estradiol, which is synthetic. Some people do great with progestins, which we talked about before, which are synthetic. And the estrogen that's in Nextstellis is fetal liver estrogen,
That
which,
Estetrol, right?
it's not extracted from fetal liver, it's made in a lab, but how natural is it to take an estrogen that's really found in fetal liver, right?
Oh, the natural synthetic argument is so fascinating to me. But as you say, just take a look at what if they're telling you something is bad, a drug is bad. They're probably selling you something. Like it's so nuanced with medications and with women and oral contraceptive pills can be highly valuable for a range of folks. And there seems to be kind of like a shaming might be a strong word, but there does seem to be a lot of shaming out there about natural and synthetic and birth control pills. And I mean, we can even dive into statins being all these terrible things. And it's really so much more nuanced than that. I just sometimes the drama is a sign that you shouldn't be listening to that person.
Yeah, and I would say there's actually a lot of dark money that's funding anti-birth control pill content. It's sort of right-wing Heritage Fund Foundation type money. So this, oh yeah,
I never thought about that, but that's a great point.
yeah. So keep that in mind that the stuff that is appearing organically, there's that word, on your social media feed is almost certainly not appearing organically at all. So when people demonize classes of medications, that is a massive red flag. It just really is. Because that it's also really, I would say, a conspiracy theory, because then it suggests that people like you and I are hiding things from women, right? So it's
Mhm.
a soft entry into conspiracy theory taking. And I see women who are now suffering harm because they don't want to go on birth control pills because of what they've seen online. And, super heavy periods that maybe, tranexamic acid isn't helping. They have polycystic ovarian syndrome and they really have androgenism associated with it. And they would really benefit from a potent estrogen. Women in perimenopause with terrible mood related symptoms due to loop ovulation and all of these things could be well treated with an oral contraceptive. And people are just, I mean, for a lot of women, menopause hormone therapy is going to make you feel worse in perimenopause, because you're adding more estrogen on top of high estrogen.
I think that's such a key point about mental health too, when you're talking about PMS and PMDD and how those huge fluctuations in hormones can dramatically affect people. And not to mention the very basic idea of preventing pregnancy. If you don't want to be pregnant, you can get pregnant during perimenopause. You may be ovulating, and so that if you have sperm in your life, we need to figure out. And you don't want to be pregnant, then we have to figure out how to help you. So sometimes a birth control pill checks a lot of boxes. It's not bad or good. Drugs are not bad or good. We don't think that way. We look at the person, we find out what it is that their issues are. We evaluate the drugs that are available. We look at the evidence. We look at professional associations and what their recommendations are, and then we prescribe it. It's not based on a pamphlet that we got in the mail from a supplement salesperson. It's
Right.
so much more nuanced than that.
Well, I have really enjoyed this, and I'm so glad this is our first time actually chit chatting. But I'm hoping that we can do more at another point because I learned a lot, and I think there's so much medication related content that we could talk about. But I just wanted to give you the final word. And is there anything else you wanted to add about the hormone therapy shortages or anything about menopause hormone therapy in general?
Oh my gosh. Well, that's a big topic. Well, first, I just want to say it's been an honor to meet you. I have followed you for a long time, and your voice is so important in every way, not just the women's health way. And so I would just encourage women to to advocate for themselves, to learn what you can from reputable sources like Dr. Gunter, and listen to your own providers and try not to follow all of the drama. It creates so much difficulty. But there's a lot of us out there who want to help you. Most of us do want to help you, including your pharmacist. So make sure that you're nice to your pharmacist next time you see them. They probably haven't gone to the bathroom in 12 hours. They probably ate a cheese stick once 6 hours ago. But that's that's my plug for the pharmacy profession as well.
I I would say yes, please, let's end on that. Don't take the medication shortages out on your pharmacists. They have probably been calling before they even open the doors if they have a shortage all over to try to meet your needs. They really do care about you. They really are such an integral part of our healthcare team. So thank you
Thank
so
you
much
so
for
much.
joining. I will put this so everybody, I will save this. It'll go up on my Substack. So if you've joined halfway through, you'll be able to see it all. And I will put links for Holly so you can find her.
Thanks, everyone. Nice to meet you, Dr. Gunter.
Nice to meet you too. Bye bye.
Bye.